Telehealth Resource Centers, or NCTRC webinar. This is on School-Based Telehealth Center of Excellence. Presenting today is Amanda Martin. She is the Executive Director of the Center for Rural Health Innovation, located in Spruce Pine, North Carolina. As Executive Director, Amanda helped establish and grow a school-based telemedicine program from 3 pilot sites to an 80-plus site program in 6 rural school districts, which she now supervises. Amanda's areas of expertise cover a wide range, from day-to-day equipment troubleshooting to program design and implementation. With an extensive background in medical office management, she understands the importance and challenges of expanding healthcare access in rural communities. Amanda earned her master's degree in healthcare administration from the Gillings School of Public Health at the University of North Carolina in 2016. It's all yours, Amanda.
I have to unmute myself for you to hear me. Hi, everyone. Amanda Martin here. Let's see, moving right along. Anita, did you want to talk over these?
No, we're good. I think most people coming on know this. This is the information from the National Telehealth Resource Center about all the telehealth resource centers, so I think we're good.
Okay. So your tips and tricks for this webinar. You've been muted, whether you're on the phone or logging in on your computer. We are going to have time for Q&A at the end. So if you'll use the chat function to put in your questions, we'll look through them at the end. There's going to be a survey. It's a link that'll be on the screen towards the end of the presentation. If you would please fill that out, that would be terrific. We appreciate the information. And this is being recorded. So that might impact, I don't know, the questions you ask. And then the recording will be posted to the National Consortium of Telehealth Resource Centers YouTube channel, and the link is there. All right, so I'm here to talk about the School-Based Telehealth Center of Excellence. That is a mouthful, I have to admit that. And as Anita said, I'm Amanda Martin. My MHA is from University of North Carolina at Chapel Hill, and I am the Executive Director for the Center for Rural Health Innovation. And we're a smallish nonprofit in North Carolina. So speaking to a national audience, I always like to start with a little geography. So there's North Carolina, okay? And North Carolina, yes, is a coastal state, but I actually live on the mountainous western end of the state. And Yancey County is highlighted there. That's the county that I live in and am presenting from, and my program operates there. So let me give you a little bit more information about the program that I actually run, which, you know, will help you understand why I'm qualified to say anything at all about school telehealth. So the Healthy Schools program has been well, we're 8 years in now. We've just finished our 8th school year. And this shows the 4 counties where these are all schools sprinkled across the mountains. One of the features on this map is the Mount Mitchell, which is a mountain in the Appalachians, and it's the highest mountain this side of the Rockies. So when you see those green schools, those little green dots sprinkled along there, they're actually, you know, down in the valley around a very tall peak. You know, for the eastern side of the country anyway, it's very tall. This program has been growing over the last 8 years to include all these schools, and it's been fairly stable with these 54 schools for several years now. And then this past school year, we just got all crazy, and see the new map, we expanded our services across the state. Now, if you're not super familiar with North Carolina, that's fine. I would just make the point that when we added 23 more schools to our network this year, it was actually kind of easy, frankly, because we were not doing it alone. We're in collaboration with the organizations that are present in those school districts and in those counties, and have great partnerships there, but also we're still in state, right? So when we're providing telehealth services, you know, my providers are licensed in North Carolina, and honestly, as soon as you're not in the same room with somebody. It doesn't matter if you're in the next building or the next city or all the way across the state. And so we found that with appropriate collaboration with local people, literally in the building, we've been able to be very successful expanding. So this is where we are. We're currently in 77 schools with 1 full-time nurse practitioner. It's crazy, right? We have some more capacity to fill and more needs to meet. So here's my team. So the folks on the left make up our entire staff. Several of those people are part-time, I would include. And we all work to make the thing on the right happen, right? So this is where you've got a school nurse with telehealth equipment evaluating a kid. And he's acting. He's not really sick. And I had permission from his mother. Don't worry. But this is how the magic happens. And so just to brag on what we do a little bit. So this is this school year. We had more than 1,000 telehealth encounters this school year. My staff, including myself, drove more than 17,000 miles to support the program. Okay, this is not, the medical care happens by telehealth, the support of it does not. But this is where it gets really interesting. We saved 942 school days by providing care in the school. So part of the reason why care in the school makes sense is because as soon as a potential patient says, gee, I don't feel good, or the school nurse evaluates them and says, bless your heart, I think you need to be seen, that person is leaving the school building. And I don't know about where you live, but around here, if you have to get picked up from school, you're not coming back that day. Even if you have a quick visit with your doctor and you could come back, people don't. So more than 86% of our visits were able to stay at school, which is kind of awesome. And then there was another small percentage, that other 36, where patients had to go home, right? They're contagious or they were that sick, but they were cleared to come back the very next day. And the magic there is that if a child presents at the nurse's office straight off the bus, already feeling poorly, if we were able to, say, diagnose their strep throat or their pink eye, which would otherwise get them ejected from the school appropriately, if we can diagnose that at 8 a.m. via telehealth from the school nurse office, and the parent gets there promptly to pick the child up and get them the first dose of an antibiotic, they can come back to school the next day. As opposed to if they were picked up later in the day and then get a appointment at a walk-in clinic somewhere else in town, maybe 3 or 4 or 5 in the evening, they're not coming back to school the next day. So it's a very complicated way to say I'm super proud of the impact that we can have on these families, on these kids being successful in school. We do, of course, track what we do. So we've gotten 149 surveys back this year. Every single encounter receives a survey. So it's not a great number, but it's not a terrible number. And then in 181 patient cases is what we generally call them for additional services. And this is where that lovely staff you were just seeing, where they do all this other stuff like help a family connect to a PCP, find money to pay for a medication that's been prescribed for an uninsured child, manage referrals for care, get translators set up. And in addition, my staff has trained 60 school nurses and other school personnel to present patients with the new equipment that we deployed this year. So we've been a busy bunch, and it's a lot more than just the medical care. Okay, so now you know who I am and what we're doing. And if you're really brand new to telehealth, I'm going to fly through a couple of slides to make sure we're all on the same page, but you can always come back and read them again later. And I will be sending the slides for sharing, in addition to the video recording, I believe. All right, so telehealth terms. I love this. It's good to start on the same page, right? So the big deal with telehealth is that there's a connection, right? There's one side connecting to the other side. And I like to start with the distant site. This is where the provider is. Now, I'm not sure why it's called the distant site. I've never quite understood that. But I will tell you that that's pretty consistent language across federal and state policies, whether it's related to what you're allowed to do or what can be paid for. So it's helpful to know. I've had sticky notes on my desk for years that remind me which side is the distant site. So the distant site is where the provider is. The provider can work from a clinic, from any kind of office. SBHC means school-based health center. So these are clinics built within the walls of a school building, or perhaps in a adjacent building in the parking lot, a trailer, that sort of thing, but something that stays at the school but is a health clinic. Could be at a hospital, could be at a bunker, which is kind of a neat idea of lots of providers managing lots of patients from a purpose-built space. The distance site could also be the home, right? So wherever your home office is could be your site. Specifically in our model, my nurse practitioners do work from home. They have, privacy, they have a door that shuts, and they're able to provide care right from their home. So they're not technically at home, they're in their office, but you know what I'm saying. The originating site is the other end, sometimes called the spoke site. That imagery doesn't always make sense because of the way networks come. I have some pretty pictures I'll show you in a minute. The originating site is where the patient sits. And this, once again, can be lots of different places. It could be a clinic, say if you're at a primary care office and you're connecting to a specialist in the big city, or a university hospital, whatever. Once again, it could be the school-based health center. There's lots of kids there, so potentially a patient there. In some cases, the home, the hospital or ED, the nursing home. And I say these are all possible. I don't want to misconstrue this to say they're all billable and acceptable to every payer, because they're certainly not. But they're possible, right? They could happen. All right, so a little more detail on the originating site. Specifically in a school-based service line, all right? We, along with some of our smarter friends who've been doing this, have determined what the minimum requirements are at these spoke sites or originating sites. This clinical station, whatever it's called, needs to obviously have a camera. This can be a webcam, it can be built into another device. There's got to be a screen because the patient and the presenter need to be able to see what's going on. And then at a minimum, there needs to be a stethoscope for the heart and lung sounds, an otoscope to see the eardrum, because arguably, we should not be diagnosing ear infections without seeing eardrums. And now I'm not clinical, but that makes a lot of sense to me. And then an exam camera. And this is in addition to the camera at the top of the list. And this camera is the one that you would use that's handheld if you wanted to show the back of the neck or the back of the knee where that poison ivy is getting out of control. Or maybe to zoom in on a ringworm on an arm or torso. And then whatever specialized equipment is needed for the kind of care that you're providing, right? That whole list of physical exam tools makes sense for acute medical care. They're not really necessary if you're only doing behavioral health. But I will say that the last bullet there, vitals, is important for all kinds of care because you need to be able to, on the originating end, on the spoke end, on the presenter end, the patient end, you need to be able to take vitals. This is usually not part of a telehealth kit that you would purchase from a company that makes telehealth equipment, but height, weight, blood pressure, temperature, sometimes O2 sat and respiration rate. These are important things and they contribute to the visit. And just a hot tip, you have to collect several of those data points in order to bill at a level 3. So there's that. So you need to be able to collect that information and make sure that your presenter is trained to do it. So sticking with what needs to be at the originating site, I love these pictures of some of the equipment that's been around for a while. So when I'm talking about an electronic stethoscope, it often has headphones as opposed to the little, the stethoscope that you see commonly for in-person use. The exam cameras range from the one that you see here to much smaller, and some are bigger. And I've seen otoscopes that look like that, and I've seen some that look very different, but they get the job done. Anymore, there are increasing options for mobile solutions, things that just click right on to an iPad or an iPhone. The sky's really the limit with the options out there, and this webinar is not meant to help you select equipment for certainly, but it's worth mentioning that you need to have more equipment there than just a telephone and more than just Skype, because of course you need to set up a HIPAA compliant kind of a connection. All right, so why schools? So telehealth is really neat. Everybody's getting excited about doing telehealth, but not everybody who's interested in telehealth understands the perception or the perspective of bringing healthcare to school. So let me tell you a little story. One of the superintendents in a neighboring county, so the superintendent of the school district, had me into his office several years ago to talk about this. And he explained it to me like this. He said, okay, when kids are in kindergarten, it's not that big a deal, right? they miss a day of school here and there. They don't feel good. They want to go shopping with grandma, whatever. It's not a big deal, right? So you have these families that will casually let their child miss, say, 1 day a month. And it doesn't seem like a lot, right? But if they do it in kindergarten and first grade, then they'll probably continue to do it. And going to school doesn't feel like a super urgent thing. But if you're in that habit, you can see this pretty easy math here, right? 1 day a month, not a big deal. But when there's 10 months in a school year and there's 13 years of school from kindergarten to 12, there's only 185 days in a North Carolina school year. And if you casually miss 130 days, you're going to really be behind. I mean, at that point, you've almost lost a whole year of school cumulatively. And Mr. Garrett, the superintendent, says he wants his kids at school every single day, no excuses. And his entire focus is on the students to graduate. And I'm right there with him. They need to graduate. This is from the a spring of 2008 Health Affairs magazine article, but basically saying that a high school graduate will have an increased life expectancy of 7 years. I mean, if you just think about that, that's amazing. Just by virtue of all the things that come together to make it possible for a student to graduate. So this is why we try to impact healthcare at schools. We bring it to them to make sure they're healthy and ready to learn. School nurses, school nurses are critical, and they vary dramatically across the country in the scope of their work and how many are staffing each school, how many hours they get to spend in each school. And I will go ahead and insert right here because somebody always asks me, no, all of the schools we serve do not have a school nurse full-time. Most of the schools we serve share a nurse. So I'm just putting that out there. But what we're aiming for here, and the reason why we want to make telehealth possible, not just for acute care, but for all kinds of different service lines, because we want kids to stay at school, to be there every day, to have no excuses to miss school, and to graduate. Okay, so how do you do it? I mean, it's super easy, right? You're watching this webinar, you're pretty much halfway there, except that there's like a lot more steps after that. So this list of bullets is not particularly in order. They're just things that need to happen, not linear. Lots of things happening at the same time. And so the educate is your community, your school district, your medical community, the staff of your agency or entity, whoever that is. Survey, in this case, I'm talking about not post-satisfaction survey. This is on the front end. This is figuring out what the need actually is. You know, we've certainly talked to schools where they said, well, there is a doctor's office right across the street, but it's a busy highway and you can't walk there. You still have to have a car. Or there is a wonderful provider's office, but it's in town and most of our kids go to schools that are in rural areas. And there's a barrier to getting there. But you got to find out what the need is. There may be lots of pediatricians, but no specialists. There may be lots of, I don't know, but it's going to vary by community. And just because you think it would be cool to provide nutrition services into the school district, if there's actually already a solution for that, then you might be wasting your time. Program models we'll come back to. There's lots of different ways you can set this up. Equipment, like I mentioned before, there's lots of shopping you can do, but I would urge you, very urge you, to put equipment way down on your to-do list, because it is not hard to buy telehealth equipment. That is probably the easiest thing out of all of these, because the equipment is available. There's great stuff out there. Some of it is even affordable. And I would make the case, and I hope you're listening, but I would make the case that you definitely need to figure out what you're going to do and how you're going to do it before you ever shop for equipment. Because you're better off to go to the vendor saying, here's what I want to be able to do and how I want it to work. Do you have a product for this? Instead of letting them tell you, here's what the product is, now go build your program around it. I urge you to decide first what you're going to do. Workflows are important, both on the provider side, the distant end, and on the patient side, on the originating side. How are they going to get there? How are you going to refer a child from coughing in the second grade classroom and being sent down to the nurse's office all the way through your process of being seen and being consented and talking to the parent and the pharmacy and back to school? And did they get a note to excuse them? Work out all those details in advance as much as you can. And this is a great way to get all the right people involved, right? You got to talk to the front desk at the school because they know part of that workflow that you have no idea unless you happen to be the one who works in the school. The launch can be kind of a non-event. The launch can't happen until you test everything and try everything. And then I can't say enough, evaluate. And there's some things you might want to evaluate that your funder doesn't even ask for, like some of the things that I was talking about with our program, like school days saved. We also evaluate the uptime of our equipment and how often it works and how often it doesn't work and what we can do about it. So making a plan to evaluate is a great idea before you go too far. Okay, so let's dig in a little bit more on choosing a model for the program. And so model can mean a lot of things, but there's stuff to consider are if you're already operating as a school-based health center, which I know a lot of people who get interested in school telehealth are already a school-based health center looking to cut costs or expand. What are the services you want to provide? Is it counseling? Is it psychiatry? Is it acute medical? There's lots of different options there, but it's important to sort of pin down that scope before you get too far into it. Who are your providers going to be? In the world of school-based health centers, there is a term called sponsoring agency for a school-based health center, which is usually where the provider comes from, where the billing happens, that sort of thing. Whoever you are listening to this webinar, you're probably the sponsoring agency. But it could be a university, it could be a hospital system, it could be an independent 501c3 nonprofit like mine. And then who are the champions in the local area that you're looking to serve? Is it a principal, a superintendent, a school nurse, a community member, a pediatrician? You need somebody really on board pulling, because just pushing programs like this into schools, I promise you, never ever works. What's the connection going to be like? Schools, as far as I know, pretty much have pretty good internet. I don't think that's only in North Carolina, but can you use it? Can you share it? Do you need a wireless connection? Are they going to have to put a booster in the room where you want to be? Those sorts of things. And then what's reimbursement going to look like in your situation? And I'll go ahead and give a little teaser here on the reimbursement. It varies by state. It varies by Medicaid policy. It varies by private payer policy. And there is a really great resource for how to find out what the deal is in your particular state about reimbursement. And it's going to be on like the third to last slide. So you have to watch the whole thing. Okay, let's look at a couple models. This is where the hub and spoke comes from, the distant and the originating site. This actually sort of describes my program. So the Health eSchools program that I run, the hub is wherever my nurse practitioner is, and the spoke are those 77 schools scattered across North Carolina. Another popular model is school-based health centers. So this is where a clinic is built out on a school property, but the provider maybe originally was going, Monday at this school, Tuesday at that school, Wednesday at that school, Thursday at that school, Friday at that school. So they were really only available 20% of the time to any particular group of kids, which is fine. I mean, that's better than nothing. And it certainly lets you schedule things like well visits and things that the provider has to be present for. But the other 4 days of the week, those kids better not get sick, right? But if you apply telehealth here, you could link all of your school-based health centers together to make it possible for that provider, wherever they are, to link back to the other centers to provide the acute care as it is needed on any given day. And then I love this picture. This is my favorite one. And this is how a lot of telehealth programs end up looking, with lots of hubs, lots of spokes, lots of different ways to connect to lots of different things. And I really hope that one day everything is connected by telehealth. It's getting closer and closer, but I would say we're not there yet. Okay, more part of that planning is your presenter. And now in this picture that I've had for a long time, the lovely young lady there, a student at this elementary school, is there in the nurse's office, and there's telehealth equipment there, all right. But without a presenter, it does not do her any good, okay? So just placing the equipment in the school and having a kid in the school does not magically make it happen. So your telehealth presenter in so many models is the school nurse. Doesn't have to be, but in many cases it is. In some cases, there is a completely separate person sent to the school just to be the presenter. The program up in Branch County, Michigan, I believe, operates that way. There's also one in Rochester, New York that has a presenter on call who will jump in the car and go wherever they're needed. There's lots of ways you can do a non-school nurse presenter. In our model, we use the school nurse for the most part. Sometimes there's another presenter in the school, maybe the secretary or someone who is a first responder in the school will also be trained to present. So then you got to determine what your training requirements are going to be. I would make the case that to operate telehealth equipment, you need to be able to operate equipment. You don't have to be an RN. So far, I'm not aware of any statewide regulations that say the presenter has to have certain credentials except to be trained appropriately to do that. All of the clinical decision-making happens on the provider end, not on the presenter end. So that's an important thing to consider when you're trying to justify who your presenter needs to be. So school telehealth got a nice thumbs up from the Journal of School Nursing a couple of years ago. We were really proud of this because some school nurses feel like they've already got plenty of work to do, thank you very much, and they don't need to be part of more. They don't need more things on their plate. And so this perspective that the school nurse can up her game, can do more to meet the needs of the children in their care, I think is pretty exciting. And it makes a nice resource if you have school nurses who aren't sure they want to do this. But the school nurse is not always the perfect solution. You've got to get them trained. There's turnover in those roles quite often. Like I was saying, a lot of schools don't have a full-time school nurse, so maybe she's only there 3 days a week, or she's only there in the mornings and not the afternoons. So it's not a perfect solution. In some cases, changing the scope of a school nurse's job is going to be a real nightmare, depending on who their employer is and what flexibility there is there. So it's not straightforward. Okay, so moving on from the presenters, let's talk about that needs assessment. I kind of dabbled on this, but I would say that as you're designing this needs assessment, consider what does your community actually want? What questions do they have? That could be really telling. Who will actually use it? Who's it going to be available to? And who will actually use it then? And where's the opposition coming from? Oh, and I could tell you 100 stories about all of these, but these are the big questions. So for example, how about, one I overheard, this was great. Oh, well, we don't need that. That's only for the poor kids. We have good insurance, so I can just take them to the doctor. Overheard at a football game. and I loved it. I was really glad to have that feedback because it let us frame our program as serving every single child in the school, regardless of their insurance status and regardless of their ability to pay. And to make sure that we put that forward. That the idea was that that mother wouldn't need to leave work or make arrangements for her other children to get off the bus or whatever if she took advantage of this. And it would also increase her child's seat time as opposed to just, well, you don't have any other options, so you have to use it. Opposition can come from surprising places, and I would warn you of the bobblehead. Okay, we've all been in a meeting with somebody who just nods their head constantly. They nod, they smile, oh, that sounds good. Yeah, and they nod some more. And really, they have no intention of helping you be successful with your program at all. And sometimes it can be hard to tease out who that's going to be. But I would warn you to dig around and look for that so that you can address it head on. And the example there is the school nurse who was in part of our pilot 8 years ago, who had equipment in her office for several months and never presented a single patient. And I'd call her or see her in meetings, and it was great. Just there was nobody who needed it yet. And so when I went over to check on her in person and went in the office to turn on the equipment and just do a check, it wasn't plugged into the wall. She had no intention of participating in our program, but she wasn't going to tell me that. So she was definitely opposition, but she was well hidden. Okay, when you're playing in schools, you need to know about FERPA. Okay, so hopefully we're all healthcare folks. We all know about HIPAA, but FERPA is, the school version of privacy rules. And this was another one, overheard when a parent came up to me, not really even overheard, but a parent came up to me one day when I was trying to share information at a middle school. And she said there was no way she would let her kid get health care at school because her medical chart was nobody's business. And she was quite adamant. And so once again, I realized we needed to do more marketing around and explaining just how much information will be shared back and forth. And so the kinds of information we want from schools are things like attendance. And if we could get it, we would love to know things like final GPA at the end of the year and if they progress to the next level of school. We can't always get that level of detail, but it would be great. The kind of information that's on the HIPAA side that we want to share with the school might be something like, it's not pink eye. You can come back to class, right? So that's not their whole medical chart, but it's just enough information to let the student stay in class. Okay, so at this point, we're kind of halfway through, and I want to throw in a reminder that there is a Q&A function, and you are welcome to jot down your questions there. I can't see them as we're going. We're going to address them all at the end. So I'm sorry if you were asking a pertinent question at the time and I didn't see it, but you're certainly welcome to jot things there and we'll come back to them. Okay, so that's a little overview of how you get going. Let me tell you about some of the work we've done more related to the Center of Excellence and how it has sort of grown over time. So 4 years ago, when the School-Based Health Alliance annual meeting was in Austin, Texas, a group of us got together, everybody who we could find who was already doing school telehealth. And if your program is represented here, we're thrilled to see you. But there were a lot more. There were actually 18 programs represented even 4 years ago. And we also had there someone from a funder, state health departments, all kinds of interested parties. And all at different stages, right? Some programs were operating for 5 years and more. I guess in 2015, we'd been around for 4 years. And out of that group, this was kind of interesting. The most visits that had happened in the past school year was 420. And of course, the range was from 0 or just a handful up to that. The working group spent a full day sharing ideas, talking about best practices, talking about evaluation, and what the ideal model is. And so when I told you, well, here it is, it's on the next slide. So we came up with this, and we said that these were the minimum requirements. As the ones who were doing the work already, we said this is what we feel like should be happening to call yourself a school-based health center using telehealth. That you have to be available to all students. And let me just repeat that. This is a little soapboxy for me, but it's really important. School-based telehealth should not only be available to the kids who can pay to sign up or who can swipe their credit card to receive care. It should not only be available to kids who have a certain kind of insurance. If it's going to be in the schools, it needs to be available to everyone. We provide care to students regardless of their insurance status or ability to pay. If they're completely uninsured, we have a very generous sliding fee scale that essentially means that no child who can't afford it is going to get a bill. And so we try to make that as easy as possible. And I would say that that's a critical component of any services that happen in a school. Providing primary care, the acute care services really make a big difference in keeping kids at school. And to do that, you need this minimum equipment we talked about earlier, a stethoscope, an otoscope, an exam camera. You have to work in collaboration with the school. You can't just sit off to the side. If the schools don't support the program being there and give feedback and talk back and forth about what the needs are and are they being met, then you're wasting your time. And then the last piece that's super important, we are not urgent care located at school. That's not what we're doing here. We wouldn't be a school-based health center if we were just an urgent care that happened to have some space in a corner at the school. And the way that we, in many cases, distinguish ourselves is this whole list of requirements, but important is getting that information back to the primary care office. So if the entity running the school-based health program is not already that child's PCP, so, poof, it's already in the chart, it's the responsibility of that school-based program to push the information to the family, to that child's primary care provider. And that does not mean it's available on the portal if they want to go print it out. It does not mean printing out the encounter form and sending it home in the backpack. It means sending it to the other provider. And it's just the same if you were at your primary care and they sent you to cardiology, the cardiologist would send a note directly back to your primary care provider. It works just like that. But that is arguably the requirement, one of the requirements to call yourself a school-based health center. Let's see. If you want more info, I'm going to show you just a couple of things that really are the national perspective on how this can work. Okay, so the American Academy of Pediatrics, they finally came out with their statement on what telehealth could look like for children. This is not specific to schools, but it's telehealth for children. They say that healthcare should be provided in the medical home. Wait, what? And you know what? I don't disagree. If every kid could get to their medical home every time they needed to, that would be great. I would be out of a job and we wouldn't worry about it. I would find something else to do. We know that's not the case. They understand that providing healthcare in schools eliminates some of the access barriers that plague families. And if you do it right, if you send that note to the primary care office, you can reduce the fragmentation of care. Another national organization is the American Telemedicine Association, and they have published operating procedures for pediatric telehealth. Some of the key points there: you got to have consent from the parents. You need to find out what that medical home information is so that you can send the note. Parents have to be involved, and it's important to figure out what your scope of services are and stick to them. And don't forget FERPA. So this sounds familiar, right? And then there's some fun language in here about, you know, the presenter should attempt to obtain verbal consent before an encounter, and parents should be allowed to participate. So if you need this kind of language for addressing pushback from any of your naysayers, this is a good place to get it. It goes on. There's more confidentiality, collaborative relationships, all important stuff. Now, the other national organization that I would say you should definitely be looking at is the School-Based Health Alliance, and they have a series of core competencies, which is a whole multi-hour webinar in itself, but these are the high points that school-based healthcare needs to address these things. And you'll see right there at the top, access for all students. I didn't dream that one up. And it's got to be coordinated, and you have to address sustainability. What are you going to do after the first couple years grant runs out? So here's a couple of your resources. If you're not already very familiar with all of these, I would love for you to jot them down. The Mid-Atlantic Telehealth Resource Center is the one that my state falls in, but you remember the map from the beginning. Everybody's got a telehealth resource center. Don't miss them. The bright orange one there on the bottom right, Center for Connected Health Policy. These are the guys who can tell you state by state what your rules are. They make it super easy to find out what the rules are in your state. So by all means, visit their website and put in your state and see what you can find out. I have also highlighted the South Central Telehealth Resource Center on here. Their website is learntelehealth.org, and they have an amazing treasure trove of videos. And they range from tele-what to really detailed training kind of things, and can be really helpful if you find that just waving your hands around and saying telehealth a lot doesn't communicate what you're trying to say. I've used their resources quite a lot. Okay, so where did this collaboration go, right? I told you about Austin, and that was the beginning of a nice thing. But here over the past couple of years, a more formal collaboration has come together between the School-Based Health Alliance, the Mid-Atlantic Telehealth Resource Center, and the Center for Rural Health Innovation, which is my organization. And these were our intentions, right? We want to share what we have. We want to develop and promote best practices. We want to make sure that there are real life examples available for people who need to understand how it works, and to keep the discussion going. And out of this is coming this School-Based Telehealth Center of Excellence. And I feel like there should be a bit of a drum roll, but I don't know how to do that through this webinar software, so we're just going to keep charging ahead. So let me tell you a little bit about nitty-gritty what we've been doing for the past 6 months to push along the Center of Excellence concept. We hired a research associate, a grad student, who has been digging, okay? And here's what he says. He says, we found 82 distinct programs in 32 states. Now, these are only the ones that we found online, right, or that we already knew about. So if you have a program, but you haven't made it searchable on the internet, you're not in our count. And as you can see, he talks about the size of each program. Some are just a couple locations. Some are much bigger. with an average in the dozen or so, 14. And then, of course, snooping on the School-Based Health Alliance census report, there are 267 telehealth exclusive school-based health centers that reported into their census. There's some good information in there too. And there are partnerships all across the country, right? There's school-based health programs everywhere. But our intern specifically said that what he's seeing is, and these are preliminary results, right? That the states that have authorized Medicaid reimbursement for school telemedicine, or they have lax laws related to it, and I again go back to your Center for Connected Health Policy and see what the situation is in your state, or they have a state that has a lot of telehealth going on, or a state that actually directly appropriates money to support school-based health centers, like North Carolina. You're going to see more and more telehealth growing. So we've been doing this sort of survey to see what's out there because we want to have a handle on who's doing what. And of course, there's a lot more detail to this that'll be coming out. But there's some other pieces output to Ben's research that I will share with you. So this is kind of coming soon. I'm not truly sharing all of the output now. So the registry mentioned here in the first bullet is what I was just talking about. There are lots of resources already out there, but they're a little scattered. And so we're trying to pull all of that together into one place. And that's coming along. Ben, our intern, is doing some interviews of experienced school telehealth practitioners in order to pull together best practice guidelines. And I've read the rough draft text of a lot of those interviews, and there's some absolute nuggets and gems in there of good stuff that I'm looking forward to sharing more. And then looking to see, actually doing that analysis of this registry we've put together to see why programs flourish and what services they're providing, and which kind of models make the most sense. So all of this information is going to be here on this website that's called the School-Based Telehealth Center of Excellence. And I just snuck this little screenshot because it's not actually up yet. I'm so sorry I don't have the link to give you today, but it won't be long. And by not long, I mean days or maybe a week. It's really almost ready. But I certainly didn't want to give a webinar that was just me walking you through a website. So it kind of works out that I've built up to the point of saying it's not ready yet. But it's really soon. And what we're going to have there are the best examples and the output of this research, and hopefully to try to be a one-stop shop for the examples you need, the templates you need to be successful. So I'm going to kind of stop there with my prepared slides, and I will click through two more things. First, this. Thank you for attending the National Consortium of Telehealth Resource Centers webinar. This time with school telehealth, but next time, because it's on the third Thursday of every month, next time will be an overview of cybersecurity, and that date falls on July 18th at the same time. So whatever time it is where you are now, that's when it's going to be. And then this is the link for the survey, but you'll also see it. It'll pop up on your screen after we close all this out. It should be in your browser. So you don't have to do it right now, but if you want to, you can. Okay, so I'm putting up as kind of a last slide my contact info. I'm happy to do my best to answer any questions you send me. I'm Amanda Martin at crhi.org. So that said, I think it's probably time for Q&A.
Thank you, Amanda. This is Nita. I wanted to thank you again. And yes, you have several questions that are awaiting your response. If you want to read the question and then respond.
Okay. I'm just going to start at the top. What about telemental health? Does a provider have to be a licensed clinician, or can they set up the program to get access to an LCSW or clinical psychologist? Huh. Does the provider have to be, I'm sorry, I'm not 100% sure I understand the question. So certainly all kinds of services can be provided into schools via telehealth by a licensed clinician, but the entity that sets up the program doesn't have to employ those clinicians. They could be contracted from another service. I'm not sure, Brianna, if I didn't get that quite right, will you retype it? I'll look for it down the line here, okay? What, if any, requirements are there for parental permission for the use of telemedicine? Okay, this is a great one, and we kind of skimmed right over it. Anytime you go to the doctor and they hand you the clipboard, they're asking for your consent and all of your information, and it is exactly the same with school healthcare. The challenge of doing healthcare at school is that generally the parent is not present at the time the child needs care. And so most programs I'm aware of send home an enrollment form, the paperwork at the beginning of the school year, hoping that it comes back. And then it's there if the student needs it. And that can be tricky. Now, our enrollment form includes the explanation that the care will be provided by telehealth. I believe that varies by state, how much you have to clarify what that means. And so it's not special, but you absolutely have to have parental permission, just like you would if you were providing the care in person. Am I aware of any school-based health centers in private schools? I'm going to say no. I don't think that I personally am. That doesn't mean they don't exist, and I will throw that one to our intern, that he should keep paying attention for that. That would be very interesting. I know that there's been some interest from private schools, but we have not been part of that. And I think some of that comes from the funding, frankly. So often the funding from, for example, from state or from foundations, they're trying to reach public school kids. All of our schools are Title I rural schools located in HIPSA areas. So that's not really where you find the private schools. Okay. This question is, I came on late, so I may have missed this. Who is the primary provider? Are you linking the student or patient to their own primary care provider, assuming that provider has telehealth capacity? Or are you connecting to a primary health provider in the community who's blocked off time for telehealth only during the school clinic hours, and who bills? That's great. Okay, so you gave like 3 options there, and they're all totally possible. So in our scenario, in my model, the provider is a nurse practitioner who works for my organization. Oh, can you make that question come back? It had a lot of pieces. Here, I found it. Nope, I didn't find it. Okay, anyway, so the nurse practitioners work for my organization, and we do the billing, and they are available all day, every school day, 8 to 3. And that's how we chose to set it up, and it's an expensive way to do the model, but it can be done. The ideal, if I could have my way, every time a student walked in needing care, they would get to be in a slot with their primary care office. We're not there yet, but I feel like it's coming. I would love to have every provider in our community have the capacity to work in a patient, or, because they're already having work-in patients all day long anyway, right? I used to manage a family practice. I know perfectly well that the schedule shifts all day long. People cancel at the last minute, they no-show, you squeeze someone else in. Why couldn't every single provider in my community have slots every day that, some of those open slots could be filled with telehealth? We just haven't gotten there yet, but I think it would be wonderful. But who bills is specifically whoever the provider is. Now, in telehealth, in some cases, it works to bill on both ends of the connection, right? But the professional code, the 99203, is billed by the person who provided the care or their entity. On the side where the patient is, that's the originating side, which might be the school, there is a code that they can bill, that entity can bill. So maybe the school, if they're a Medicaid provider and they're already billing Medicaid, they may also like to try to claim that. It's about $20. I know that in the state of Georgia, they've been very successful with that. So I would certainly encourage you to reach out to they used to be the Georgia Partnership for Telehealth, but now they're the Global Partnership for Telehealth. But somebody there may be able to clarify how that works. Okay, let's go on. We operated a large telehealth program, which included school-based telehealth in response to the school-based health centers not being able to sustain economically. Absolutely. One of the big problems was our inability to provide to primary care, as we were not willing or able to keep vaccines on site. Do you have any recommendations? Yeah, so my snarky answer is drones. I think it would be great to just send those out by drone, but I actually don't have a great answer. our program has never been able to be the primary care doctor for a student, which means we're not doing vaccines, we're not doing unclothed well visits. We will do a sports physical or pre-participation physical, but they always come with a referral back to the primary care provider for a full physical. I'm sorry that I don't. I love the idea of collaborating with a bigger clinic or your health department to do vaccine days, where you schedule all the people you need and you bring exactly the vaccine you need. But I couldn't say that we've been able to successfully do that. Can you share information regarding any upcoming school-based telehealth conferences? Oh, now that's a fun question. I wasn't prepared for that one. I mean, the School-Based Health Alliance is meeting next week, so that's a little bit short notice. No, I sure can't. We'll have to work on that one. Thank you for the question, though. And the next question here is, how is your program funded? And then the examples: grants, third-party billing, contracts with schools. Okay, so 2 out of 3 of those apply to my program through Center for Rural Health Innovation. We are largely grant funded and have been for 8 years. And we have received federal grants, state grants. We're considered a safety net provider by our state, and so that gives us access to a grant stream there. And we certainly do bill insurance when we can, and we'll send a statement to the family for a copay, or even a, it went to your deductible. It's kind of a big bill. But I would say arguably our third-party billing does not cover all of our expense. Do you remember that slide I showed that had all those miles driven and all that extra work that we do, all the hustle we do to try to make it all happen? That's really not accounted for in the reimbursement rate from Medicaid or even from private insurance. And of course, we need to absorb the cost of taking care of the uninsured patients, or the ones who are never going to be able to pay their giant deductible, and therefore send nothing, and they end up essentially being charity care. So funding is definitely a tricky thing, because there's, you would think the equipment would be the big thing, right? But anymore, the equipment doesn't have to be terribly expensive, but you do still have to operate your program. Oh, somebody answered a question for us. In Colorado, public, charter, and private schools all participate in school-based telehealth. Awesome. Thank you so much for sharing that information. So Colorado has examples of all kinds of schools. Okay, next question. Can you go over the billing and payment cycle? Assuming the provider is billing, are they billing the patient or the school? Is the payment method set up ahead of time, like the parental permission with a credit card, or insurance information on file? Aha, this is a great question. Okay, so I'm not aware of any schools that are going to step in and pay for the medical care of their students over and above what they're required to offer through the school nurse, right? So the way that our program is set up, and as far as I know, most of them are, is the provider, whatever entity that is, the provider is going to bill the patient's insurance, okay? If they have Medicaid, if they have private insurance, whatever. And if they're uninsured, then they consider a sliding fee scale and maybe send a bill to the family. And that information about their insurance is collected in advance at the time of enrollment, right? So we're trying to collect that information when school goes back in the fall, even if we don't see the child until March. And then, of course, at the time of the visit, we're going to be in touch with that family, and we can verify that information, and it's very likely that it has changed. And so we'll ask them for the change of information so that we can try to bill. The schools, I will say, the schools I've ever talked to absolutely want nothing to do with medical billing. So I would be surprised if you found one that did. And as far as a credit card, we never ask the families for money up front or billing information. I can't even imagine that I could get a parent to write down a credit card number on a piece of paper that was going to go in the backpack. That seems unlikely. And also, it would be a serious barrier to care. And so much of what we're trying to do is to reduce the barriers to accessing care. And if you're required to have a credit card in order to access the services, then poof, you've just cut out half the kids, in every school we serve. And it may be different places, different in other places, but certainly the kids we're serving don't all have credit cards. Here's another piece of information. Thank you for sharing. In Nevada, both originating and distant sites bill and get reimbursed. So that's great. So the schools or where the school-based health center where the patient is can also bill and get paid back. Okay. Right, and then the follow-up question related to the school's billing for the facility fee was addressed to Kirk Gillis. How are your schools set up to be able to bill for the facility fee? I would say arguably, Debbie, that's probably a Tennessee-specific answer you're going to need there, or Tennessee, Virginia-specific answer, because they have to be set up as Medicaid sites. In North Carolina, it was prohibitively expensive to make every single one of our schools officially a Medicaid site. It was something like $200 a year per address. And that was just going to be outrageously expensive for us, so we didn't do it. I'm going to go on to, do you collect copays from families for the insurance billing? So we do collect copays, but we do not have any money changing hands at school. So we made the decision that we would send statements to the families, right? So we're collecting all that information, of demographic information from them at the beginning, so we can send a statement to the family for their copay. But we can't do it in advance in any practical way because we're not going to ask the school nurses to keep a money box in their office. The schools would not be happy with that.
Amanda?
Yes, ma'am.
Anna clarified her question. Did you see? Okay.
Thank you. So she was asking if we were able to integrate mental health services through this model that we're using, and is there capability to do so? And the answer is absolutely, you can. We have not. We would love to be able to do that, but because of the way that billing is currently set up for mental health services in North Carolina, it's super challenging, and we just haven't been able to get around it. But I know there are other programs in North Carolina that are doing it successfully, and certainly across the country. In fact, there's one program that I find fascinating. It's in Pennsylvania, and it's geared towards the virtual high school students, right? This is an increasing trend where kids can attend a virtual high school instead of going physically to the school building every day. And they have classes, and they have teachers and assignments, and it's school. They're just doing it from the comfort of their home. But a lot of those kids have an IEP that requires them to have therapy. And so this company actually provide virtual therapy, virtual counselors to the virtual high school students. So the whole thing happens with nobody ever meeting in person. I think that's fascinating. So absolutely, the equipment is super easy. It makes so much sense. And I think you would end up with a whole lot less no-show rate. As well as getting kids into therapy, for example, who were never going to go otherwise. But if it's offered right at school during the school day, maybe it would reduce stigma and increase participation. Okay, and then this is more, I think, about Nevada, right? We utilized community providers to operate this school-based health centers, and all documentation, orders, and billing were conducted through their respective EMRs. Okay, that's helpful. Nice. Okay, I think that I've gone through all of the questions that were up here. Does anybody have anything else? Yeah, I think we're good. Anita, have you got anything else?
No, it looks great. And I want to thank you again, Amanda. And if anyone has questions, they have your contact information, and or they can contact their regional telehealth resource center.
Wonderful. Thank you so much. Have a great day.